Welcome to Primary Care Today on ReachMD. I'm your host, Dr. Brian McDonough, and with me today is Dr. Jonathan Firnhaber. We're going to be talking about skin cancer, the primary care approach to it, things like basal cell cancer, squamous cell, a little bit on malignant melanoma, and Dr. Firnhaber actually is very qualified to talk about this. He's written articles on it, and probably if you read an American Family Physician, he's written articles in there as well. And I think your background, obviously, is as in primary care, but what was your interest in skin cancer? What got you excited about looking into it more?
More that we end up seeing quite a few skin cancers at our primary care clinic in a residency program in Greenville, North Carolina. Certainly Eastern North Carolina is no stranger to the sun, and we tend to see a lot of non-melanoma skin cancers, and I do a lot of the procedures in our residency program, so certainly had to get up to speed with the proper care.
Jonathan is based at East Carolina University, and I am familiar with it only through my son, who played baseball down there many summers. And in that hot sun, even if you try to protect yourself, you still have a lot of exposure there, and there's concerns. I want to ask you a question right off the top, because I know a lot of the general public is concerned about this, but I'm sure many primary care docs as well. Is there enough of a change in the atmosphere that we're seeing increases in the amount of skin cancer perhaps more than 20, 30 years ago? Is it our lifestyle? What's going on?
That's hard to say because truly the incidence of non-melanoma skin cancer is increasing and has been increasing over the past couple of decades. And no one really is certain if that's changes in the atmosphere, that we're seeing more UV light penetration, or if people are more adopting the quote-unquote healthy tan type of lifestyle, or if it's just that we're moving to the coast more and spending time at the beach. But certainly the incidence of non-melanoma skin cancer is increasing, and there may be just an element of better recognition. Perhaps people are living longer to actually develop the skin cancers and have them diagnosed and treated.
I'm gathering the most common form you see is basal cell because it's the most common form of skin cancer. Is that what you come across the most?
Hands down. Yeah, we do see some squamous cell carcinomas, but by and large what we're seeing and taking care of day by day are the basal cells.
So when we get people in the primary care office, obviously they come in and they say, oh, this little bump's here, that one's there. And obviously you could refer to a dermatologist, and certainly in some cases, in many cases, you may want to. But when you're looking for basal cell, what are those specific characteristics you're looking for? I know radio, it's a little hard to describe without pictures, but what are those types of things you're looking for?
It is. Well, all the skin cancers and a lot of skin lesions have their very characteristic descriptions, and the most common basal cell carcinoma subtype you see is the nodular basal cells, which are classically described as a pearly papule. And if you think about basal cells not having a whole lot of supporting structure, they involute fairly quickly, but they look like little pearly papules on a little bit of an erythematous base, a lot of times some superficial telangiectasias on the surface. And that's the most common type that you see. You certainly can see the superficial basal cells, which are more like little scaly plaque. Those sometimes get mistaken for eczema or for psoriasis. The pigmented basal cells are even less common. Those more commonly get mistaken for melanomas. Squamous cell carcinomas, if you think of them being a keratinized lesion, they're typically hard, crusty with a lot of times a central ulceration. But really the big thing is having a high index of suspicion and a low threshold for doing a biopsy.
And when you see one and you decide, I'm going to do a biopsy here, what types of biopsies do you recommend? And can most family docs do it in their office?
Oh, absolutely. And most of them we do it at point of care as opposed to referring on to our procedures clinic. So we will do shave biopsies for lesions that are raised, and a simple punch biopsy up to 3 to 4 millimeters you can do without actually closing that. Cosmetic result is better if you leave that open and just let it heal by secondary intention. And that you can do a quick anesthesia with less than a cc of lidocaine, drop a quick punch biopsy and use dry sol or similar for hemostasis, and be done in just a couple of minutes. And we have our nurses trained to the extent that we can walk out of the exam room and say, hey, I need to do a quick shave, and go see another patient, and by the time we get back, everything's sitting on the tray ready to go.
When you talk about the superficial basal cell carcinoma, they get that red, scaly plaque, you get the raised pearly white borders like you're saying. There are other things that look like it too, though, right? I mean, other types of lesions that may confuse the primary care doc?
Most certainly, and the nodular basal cells are the most common ones, and I think those are really the easiest to identify. They tend to have little, again, the pearly borders, a lot of times little raised border with some central clearing. But certainly the superficial basal cells, being scaly and plaque-like, can be mistaken for all sorts of things. Bowen disease, which is squamous cell carcinoma in situ, can sometimes be mistaken as a superficial basal cell. And again, eczema, sometimes they're sent over to evaluate that this might be tinea, and people have been putting antifungal creams on them. Those tend to be the most difficult ones to really distinguish without actually having a biopsy in hand.
Tell us a little bit about actinic keratosis, because that's also something pretty common, especially with sun exposure.
They certainly are, and that's really thought to be the precursor to the vast majority of squamous cell carcinomas. And technically, an actinic keratosis is actually a neoplastic transformation. It's just that it's not until that neoplastic transformation reaches the dermis that it's considered a squamous cell carcinoma, and prior to that, it's still considered actinic keratosis. A lot of those will spontaneously resolve after the course of 9 to 12 months. But because they're considered precancerous, we typically treat those. Cryotherapy is the quickest and most efficient way to take care of them.
Do some people use, they cauterize them as well? Is that another option?
We generally don't cauterize actinic keratosis. That tends to cause more scarring and more damage than is really necessary. Because they're so superficial, cryotherapy tends to work really well. For someone who has more widespread actinic damage and actinic keratosis, such as on the scalp, 5-fluorouracil cream, which is the brand name is Effudex, can be used, but that tends to cause a lot of crusting, and it's really not a real pleasant experience for patients, but it is effective.
What about keratoacanthoma?
The keratoacanthomas are really interesting because they're one of those that they're fairly easy to diagnose by sight, and you have a very good idea that that's what it is. I always think of like a papule, and you're thinking that it looks like a squamous cell carcinoma with a plug or a little volcano of keratin in the center. They're most commonly mistaken for squamous cell carcinoma, even though they are benign. Typically, we go ahead and excise those because there is a possibility that there's a squamous cell underlying it. But generally, those are ones that are fairly easy visual diagnosis.
You're listening to Primary Care Today on ReachMD. I'm your host, Dr. Brian McDonough, and today I'm speaking with Dr. Jonathan Firnhaber. He is East Carolina University Brody School of Medicine is where he's based. He has an interest in skin cancer and primary care approach, and clearly in our offices, we see many of these cases. People come to us first. What I always find interesting is the United States Preventive Services Task Force really says there's insufficient evidence to recommend for or against screening the whole body for skin cancer. You know, it's such an important thing. What do you think the reasoning was behind that recommendation?
Well, really, it's the USPSTF, and when I think about their recommendations, they are incredibly evidence-based. And if there is not just one, but if there's not a whole host of randomized controlled trials that really prove that whole body examination and skin cancer screening in this example is definitely beneficial, then they don't really have the evidence to make a recommendation. Certainly their recommendations are in contrast to the American Cancer Society that recommends fairly frequent annual skin evaluations and recommends that patients actually do a monthly skin evaluation. And that's not an unreasonable thing. You figure that having someone slip off their shirt and take a look over their back and their prominently sun-exposed areas for skin lesions is not an unreasonable thing. It's a fairly low-risk maneuver, fairly quick and easy to do, and I think also lets patients know that we take the risk of skin cancer seriously and want to make sure that they're adequately evaluated.
Of course, one of the major concerns we all have is malignant melanoma, and I did want to touch on it just for a few moments with you. And this also is sun-related, or is this something where there could be genetic? What's the, the etiology, the leading risk factors for malignant melanoma?
So the answer is yes to all of the above. Certainly in people who have extensive sun exposure, the risk of melanoma increases, but there's certainly a genetic component as well. And folks who have inadequate basically DNA repair mechanism, they're at greater risk for melanoma. Those who tan poorly, so someone who's fair complected or certainly redheads, have a greater risk. But sun exposure is certainly at the high on the list of risk factors. When we see those in clinic or we have a suspicion that we're looking at a melanoma, probably the most critical thing is doing a full thickness biopsy. And when we're suspicious of a basal cell or we're suspicious that it's a squamous cell, doing a shave is a reasonable maneuver. Certainly if there's a pigmented lesion and you have any suspicion whatsoever, remembering that the depth of the lesion is really the critical point in determining the risk and the concern for that malignant melanoma, anything that destroys the depth gauging, it really destroys the diagnostic ability of the pathologist. So making certain that a full thickness biopsy is done is really critical.
So sometimes you may have a patient where a dermatologist does the biopsy, then the report will come back that it may be pre-malignant or pre-melanoma or at least some sort of dysplastic change. They then will go back and take the entire area and a larger border. Is that what they usually do?
Right, and we do, certainly for pigmented lesions, and I think all of us are comfortable doing a punch biopsy. For a smaller lesion, sometimes we'll do a punch that excises the entire lesion, or even do an excisional biopsy of a suspicious lesion. And then if the borders need to be expanded from there, we can refer on for that. But we have a pretty low threshold for punching out a pigmented lesion, or at least taking a piece of it to send on to pathology.
And I would think pathology, at least my experience is, I wouldn't say they overcall it, but I think they're very aggressive in calling it because it's one of those things I think you don't want to miss, right?
Right, and in a lot of cases when it's first diagnosed, melanomas have already metastasized, so early diagnosis is really a key.
We talk about the different forms of skin cancer and different approaches. Do you think we're making a difference? I mean, you obviously have taken an interest and you're working to try to educate other physicians with your articles and also probably in your residency program and with your own patients. Are we making a difference with education?
I hope so. And when you look at basal cell carcinomas and say what's the overall risk of those to someone's life, it's honestly not that much. They can cause local destruction, but they tend not to metastasize because they really require supporting stroma to continue to grow. So they don't do a good job of metastasizing. Even the metastatic risk of a squamous cell carcinoma is relatively low. It's under 10%. So when we think about is this something that's truly going to impact someone's life, it's really more local destruction and more the mental thing of having a skin cancer on your body. But even if we say that there's not a great reduction in morbidity and mortality by treating them, nonetheless, I think the education has been useful because patients are now we see that even in the Carolinas, which tends to be a sun-worshipping part of the country, the concept of a healthy tan is starting to slowly fade, and people are doing a better job of using sun protection and sunscreens even if they're out at the beach.
I mean, lately I would think the shark worries are greater than the skin cancer in some extent, right?
Yeah, we were actually at the beach last weekend, and normally it is completely full of people, and there are 4 or 5 people in the water as far as you could see. So, the shark concerns have really got people going way more than the sun recently.
Yeah, but of course we can't forget the sun. And another thing I wanted to bring up, which I know early on in my medical career, I kind of was stunned when I was in medical school, never thought about it, was the fact that we get so much sun exposure in the car, so much sun exposure during the winter. A lot of patients aren't aware of that. They just think of, I'm going to lather up when I go to the beach and put the SPF on or whatever, but they're not thinking about it all year long.
No, and car windows don't do a very good job of blocking UV rays, and as a matter of fact, clothes don't either. A lot of times a thin cotton T-shirt is really not much better than not wearing anything at all, and so you can certainly get burnt through clothing. There are some clothing manufacturers that have shirts and such that are actually have an SPF that is built into them, and they're better at blocking UV radiation, but you can certainly get burnt through clothing. You can get burnt through car windows, and in the wintertime in particular, especially if you're living someplace where there's snow on the ground and you end up with a lot of reflective UV radiation, you can end up with some pretty nasty sunburns even in the winter months.
Wanted to talk to you in the last minute or so we have of the recurrence rate. And it doesn't have to be exact percentage, but basal cell, squamous cell, and melanoma. How often do we see these things repeating in the different areas of skin cancer?
Basal cell carcinomas, depending on the method of excision or the method of treatment, have a variable recurrence rate. It's typically under 20% over the course of 5 years or more. Depending on how they're treated, if they're completely excised, especially if it's done with Mohs surgical technique, where basically the entire lesion is removed and confirmed histologically that it's out before the defect is closed, that recurrence rate at 5 years is in the 5% range or lower. If they're treated with simple excision, it's a couple percentage points higher. If you stretch and do, say, electrodesiccation and curettage, which is still a very reasonable method to treat a basal cell carcinoma, that recurrence rate may approach 10% over the course of 5 years. Squamous cell carcinoma, depending on the location and size, may have a slightly higher recurrence rate. But a lot of it depends on the size of the lesion, the histologic characteristics, if the patient is immunosuppressed, if they have other medications that may cause immunosuppression if it's not an intrinsic immunosuppression. All those are factors that will influence their risk of recurrence.
And the malignant melanoma, is that something where you get one and then you're looking throughout the body? Because I would assume you'd excise that area if you'd want to get it all at that point.
Right, and lifetime risk of melanoma goes up sharply of recurrence after someone's had a single lesion. And the tough thing is with those is that they may be metastatic by the time they're diagnosed, and those metastases may not be obvious until after someone's had treatment. So aggressive treatment, even for fairly small melanomas, is really the norm, both surgical excision and with wide margins, plus also lymph node dissection and then chemotherapy following.
Jonathan Firnhaber, I want to thank you for joining us on Primary Care today on ReachMD. We run out of time, but I really appreciate your taking the time to join us.
It's been a pleasure. It's nice talking with you.
This is Dr. Brian McDonough. If you missed any of this discussion, please visit reachmd.com/primary care today. You can download the podcast. You can learn more on the series. Thank you very much for listening.